Hi friends, today we shall be discussing hypertension. Under hypertension, we will be focusing more on secondary hypertension. So, hypertension. Hypertension can be primary, can be secondary. In primary, we usually do not have an identifiable cause. In secondary, we have an identifiable cause as well as, most importantly, we usually have a treatable cause. So, this is primary and that is secondary. So, what is hypertension? So, as per ESC 2024, European Society of Cardiology 2024, a systolic blood pressure more than 140 and a diastolic blood pressure of more than 90 mmHg is called hypertension as per ESC 2024. So, as we are discussing ESC 2024, we'll just look into the classification of hypertension as per ESC 2024. So, here we have systolic blood pressure and here we have diastolic blood pressure. We have optimal, optimal, normal, high normal, and then we have grade 1, grade 2, and grade 3. So, optimal BP is from systolic less than 120 and then diastolic is less than 80. And normal BP is systolic 120 to 129 and diastolic 80 to 84. And then high normal is 130 to 139 systolic and 85 to 89. And then we have grade 1 hypertension where the BP is more than 140 systolic to 159. And then we have here, sorry, this is 89. And then we have 90 to 99. And then grade 2 is 160 to 179. And here it is 100 to 109. And then grade 3 is more than or equal to 180. And then here it is more than or equal to 110. So, optimal BP is less than 120 by 80. Normal BP is 120 to 129 and 80 to 84. High normal is 130 to 139 and 85 to 89. And then grade 1, 140 to 159 and 90 to 99. Grade 2 is 160 to 179 and 100 to 109 diastolic. And grade 3 is more than 180 by more than 110. So this is as per ESC 2024. And we have other classifications as well, like ACC, where they define blood pressure as more systolic more than 130 and diastolic more than 80. But most commonly in routine clinical practice, we are using this as the criteria to treat. So, primary, there is no identifiable cause, and secondary, we have an identifiable and treatable cause. So, now we shall look into the details of secondary hypertension. Secondary hypertension. Secondary hypertension. So, when are we suspecting that a patient is having secondary hypertension? When the age is less than 30 years and when the patient's BP is not under control even after treating with more than 3 drugs. And when the patient's BP is under control with more than 4 drugs. Also, when the BP is very sudden in onset or abrupt in onset, and also when the BP is very severe. And when the target organ damage is disproportionate to the degree of hypertension. And also associated biochemical clues or clinical clues like hypokalemia in primary aldosteronism and Cushingoid features in Cushing disease and episodic symptoms in pheochromocytoma. So, we suspect secondary hypertension in the following patients. When the age is less than 30 years, when the BP is not being controlled with more than 3 drugs, and when the BP is under control with more than or equal to 4 drugs, and when the onset of blood pressure is very sudden or when the BP is very severe, and when the target organ damage is disproportionate to the degree of hypertension. What do you mean by that is the BP is less, but the target organ damage is severe. And then when the patient has any associated features like hypokalemia, Cushingoid features, and episodic symptoms in few. In a few patient, episodic symptoms like headache, palpitations can come as paroxysms. They are only for a few minutes and then they disappear. So, in such patients, we think of secondary hypertension. And now we shall look into the causes of secondary hypertension. Causes of secondary hypertension. The most important and the most common cause of secondary hypertension is the renal parenchymal changes. Renal parenchymal changes, followed by renovascular causes, and then we have primary aldosteronism, where primary aldosteronism is the most common endocrine cause of secondary hypertension. And then we have OSA, we have certain endocrine causes like pheochromocytoma, Cushing's, thyrotoxicosis, also hypothyroidism, but these are pretty rare. And we have certain monogenic causes, in CAH, 11 beta hydroxylase deficiency, 17 alpha hydroxylase deficiency. We have syndrome of apparent mineralocorticoid excess, SAME, glucocorticoid remediable aldosteronism, Gordon syndrome. And then we have certain drugs causing hypertension, NSAIDs, glucocorticoids, oral contraceptive pills, etc. So, renal is the most common overall, and primary aldosteronism is most common endocrine cause. Once upon a time, whenever we think of endocrine cause of hypertension, pheochromocytoma is always the first diagnosis we used to think of. But the latest literature says more than pheochromocytoma, primary aldosteronism is currently the most common cause for endocrine hypertension. So, the management approach varies for each different cause, but most of them are treatable. So, as I already said, secondary causes of hypertension are treatable causes. If not fully treatable, at least upon treatment, the BP comes under control and the target organ damage is also under control. So, this is secondary hypertension. Thank you for listening.